Hello everyone. Let's see a case of ridge preservation with maxillary premolar site. Now here is a case. The patient has a history of periodontitis and a flap surgery done around 5 years back, and she's complaining of recurring gum boil over her left back tooth, that is around 2.5. On examination, the periodontal abscess was seen and grade 2 mobility was observed with 2.5. The X-ray shows overextended GP and bone loss. Now the final treatment plan is to extract the tooth, do the socket grafting for the possible future implant placement. These are the instruments that we have arranged, right from the diagnostic instruments to bone curate, then luxator, extraction forceps, bone graft carrier, bone graft compactor, and these are the different biomaterials that we have kept for collagen mesh, for hemostasis, then graft and membrane for the ridge preservation. We have also kept the S6 retainer so as to cover the graft and membrane immediately after the procedure. There can be a variety of temporization methods options are available to the dentist. To start the procedure, articaine anesthesia is given, infiltration on both the buccal and palatal sides. Then a periotome is used on both sides to have minimum or traumatic extraction to just to sever the fibers. Then we can use the luxator to luxate the tooth slowly, and once the tooth is luxated you can use the extraction forceps for the extraction of the tooth. Once the tooth is extracted, there will be oozing, and to control that oozing we need to use some kind of hemostatic agent. This one collagen sponge comes in a vial, and you can take out the required quantity of the hemocol, and you can place it into the extraction socket as much as required to cover the extraction site. It will soak up the blood nicely in around 3 to 4 minutes, and once it soaks up the blood you can take out the, this is the photograph after placing of the sponge, and after around 3 to 4 minutes you can take it out. Now however, some amount of collagen sponge, even if it is kept or remains inside the socket, it doesn't cause any harm since it helps in the healing as well as the regeneration, the content being type 1 collagen. This is the site after the removal of the collagen sponge. Close-up view. Now we need to shift to a curate to clean up the socket, that is to clean up the granulation tissue on both buccal as well as the palatal side of the bone. Once the cleaning is done, we can do the irrigation using normal saline, preferably close to the socket walls to clean up the granulation tissue. Then use a gentle probing to confirm that the socket walls are intact. This again has to be done on both the palatal as well as the buccal wall, because the treatment factor is decided on whether the socket walls are intact or anywhere fenestration is seen or no. Once the checking is done, now here we are only planning to do a simple bone graft surrounded by membranes. So we are going ahead with the tunneling procedure on both buccal as well as the palatal gingiva using a tunneling instrument. After that, we are going to select a membrane. Here we are using a helicite membrane, that is a sheep collagen, and once you open up the vial, you can take the membrane using a tissue forceps. You can dip it in a normal saline to make it more usable consistency. Once that is done, you need to trim it as per the shape of the socket that you are treating. Here we are making it almost a dumbbell shaped. Once it is shaped, you can tuck it under either buccal or palatal flap. Here it is tucked in on the inside the buccal flap. Next step is to select the bone graft material. Here we are using a Xenograft, that is osteograft, and that has to be gently packed inside the extraction socket. So we take the Xenograft that is available into a bone well and mix it with normal saline, make it in a good packable consistency, mix it and condense it lightly into the extraction socket. You can still appreciate that the membrane is still covering the buccal wall. Once the bone graft is compacted, into the extraction socket, you can appreciate again that the membrane is covering and the graft is inside the socket. You can little overdo it to expect the resorption. Once that is done, you need to turn over the membrane and tuck it under the opposite flap. In this case, it is tucked from buccal to the palatal flap because the tunneling has already been done, so it should not be much of a problem. You need to take the IUPA to confirm that the bone grafting procedure is adequate. Now you proceed with the suturing. Here we are doing a cross horizontal matrix suturing so that it holds the membrane nicely and doesn't let the graft membrane go away. Apart from this, you can also use a simple interrupted suture. Once the suturing is completed, you can use the retainer or the temporization thing to cover the graft as well as the membrane, at least for the initial few days. This is the retainer in place and suture material is also seen. On the third day, you can see the healing process. The suture material is getting loosened up. This is the video after 1 week. You can see some inflammatory reaction at the coronal part or distally. This is the buccal view and occlusal view. At 3 weeks period, you can see almost entire of the inflammation is gone, and we can expect a lot of coverage of the extraction site. Some amount of healing we can still expect in next 1 week. That's it. Thank you. For the detailed theoretical description and scientific background behind ridge preservation, you can watch my previous video on ridge preservation or socket grafting. The link is attached along with this video.